12. And we have Dr. Bijlani, Dean ICAIOTA today. She is attending the webinar as well as two of our board members, Ghazala Magda and Karthik Mani. They are also attending the webinar. So welcome everybody. And I thank Mansoor Hussain, that's Nafeesa's better half, for coaching her on the electronics media and all that kind of stuff. So thank you, sir. And it's my pleasure to introduce Nafeesa today. Nafeesa is alumni of a Nagpur Occupational Therapy School, and we are running into each other in the conferences or any social events and things like that. So we are regularly in touch with Nafeesa. So I'm glad that she agreed to do this presentation for us. And her topic is autism spectrum disorder in infants and toddlers. So I just want to give a brief bio. She graduated from Nagpur OT School, and she did her PGCR and PGDR from All India Institute of Medical All India Institute of Physical Medicine Rehabilitation, Mumbai. She worked briefly as a clinical and a faculty staff at Vellore Medical College in India before moving to USA. That was before moving to USA. She has been practicing as an OT in New Jersey since then, and her passion for working with children led her to pursue the depth study of early childhood development. And she has been working with early intervention program serving birth to three population age group over last 30 years. Yeah. She has worked with the infants and toddlers with a vast array of diagnoses, some of which includes but not limited to autism spectrum disorder and developmental delay. She's a passionate about yoga. I know she one of social meeting you mentioned that you are a yoga teacher, so it's very nice of you. And she teaches yoga to the community people in the New Jersey area, and she speaks to us about her insight from working with the infants and toddlers with autism spectrum disorder. There's another side to Nafeesa. Nafeesa is a very kind and a generous person, and we depend on her for uh, professional development activities like she supports us morally as well as financially. So I really thank her, and we're lucky to have her as a speaker today. So without further ado, I will hand over the microphone to Nafeesa. Go ahead, Nafeesa.
Good evening or good morning, depending where everyone has joined in from. Thank you, Dr. Suple, for your introduction. It is an honor to be speaking with you all. Hopefully, you will gain some useful information from today's topic, which is an autism spectrum disorder in infants. One second, I'm just trying to figure this out. So hopefully we'll gain some useful information from today's topic, which is an autism spectrum disorder in infants and toddlers, as my experience has been primarily with this population. Let me just turn on my pointer. Let me give you an overview of autism spectrum disorder.
So, Nafeesa, are you planning to share your screen?
Yes.
Yeah, okay. Yeah, we can see
it now. Okay.
Yeah, we can see now. Yeah.
So this is my today's topic, as primarily I have been working with this population. Let me give you an overview of today's agenda. I will talk about autism spectrum disorder, and just bear in mind that I'll be using this term or ASD or autism interchangeably throughout the presentation. So we'll look at early warning signs and symptoms, diagnostic tests and sensory evaluations, sensory integration and sensory processing disorders, OT's role in early intervention using sensory-based motor strategies, and then I will end with conclusion. Autism spectrum disorder is a complex neurodevelopmental disorder. And along with these signs, it can also affect sensory motor skills, visual and auditory processing skills, and learning skills. And these can be exhibited in any combination and in any degree of severity. Numerous studies have also shown that ASD can often be comorbid with other neurological, psychiatric, and medical symptoms, along with global developmental delays and cognitive deficits like epilepsy, neuropathy, anxiety, oppositional defiant disorder, attention deficit hyperactivity disorder, immunological disorders, and sleep disorders and gastrointestinal issues, just to name a few. Since it is a complex neurological disorder, I will use a case to help guide us through the evaluation, diagnosis, and management. I'll talk about a child that I worked with. Let's call him Robert. Robert is an adorable 18 months old little boy born full term to a middle-aged couple. His family's second child. The 10-year-old sibling has some developmental disability and is in a wheelchair. His mother is a nurse and worked part-time. His father worked full-time from home. He came to my attention when he was referred for eligibility evaluation for early intervention services. I'll get back to the case of Robert later, but let's briefly look at the history of autism. It was regarded as a form of childhood schizophrenia from 1950 to 60, and it was distinguished from schizophrenia in 1980. Now, since 2013, DSM-5, Developmental Statistical Manual for Mental Disorders 5, was started being used as a standard form of diagnosis for autism spectrum disorder. Why is it called a spectrum disorder? Because each person with autism has a distinct set of strengths and challenges. Two children with autism spectrum disorder may act very differently as they don't have fixed set of symptoms. That's why there's variation in manifestation. Also, 200 to 500 genes are tied to the diagnosis of autism. People with autism can also can be highly skilled or severely challenged. So there's a variation in degree of severity. These people are neurodivergent. So let's look at what does that mean. In simple terms, people with autism have a variation of human brain, as Dr. Temple Grandin, a scientist and an author herself diagnosed with autism, puts it. They are, I quote, different, not less. Neurodivergent people experience, interact, and interpret the world in unique ways. Recently, neurodiversity has gained a lot of momentum. People call themselves autistic, a person with autism, a person living with autism. What causes autism spectrum disorder? There's not just one cause of autism. There are risk factors, biological, having a sibling or another family member with ASD, born to older parents, metabolic imbalance, extreme prematurity. 7% of children born preterm are autistic compared with 1 to 2% of children in general population. Low birth weight and birth trauma. Genetic factors include having certain genetic or chromosomal conditions, Rett syndrome, and Fragile X, or genetic mutations. But no autism gene has been discovered yet. Environmental factors include exposure to heavy metals and toxins, maternal history of viral infections, fetal exposure to medications, valproic acid or thalidomide used to treating morning sickness during pregnancy, and also used to treat skin conditions and cancers. So many hypotheses, so little proof. Current research suggests that there is no single cause of autism, but rather multiple causes working together in a cumulative way and multiple paths leading to the disorder. Let's look at the global data on autism. It occurs across the globe in all racial, ethnic, and socioeconomic groups. Higher incidence in male to female ratio is 4:1. And if you look at the world map, let me just get my pointer back. The region in yellow, Indochina area, these are all the documented incidences of autism spectrum disorder. So we start with the low incidence here in the Indochina area, slightly higher incidence in green areas. And as the blue shade gets darker, there's higher incidence. So highest incidence in Canada, Japan, and South Korea. In United States of America, prevalence is 1 in 44 boys and 1 in 189 girls. New Jersey has the highest rate, 1 in 35. That's where I live and work at. 1 in 100 around the world. And some of you may be surprised to hear the incidence is predicted to be 1 in 2 births by 2025. So this is a highly relevant topic, and I'm sure will touch all of you in your lives and careers in near future, if it hasn't already. Some have dubbed this increase as autism tsunami. Let us look at how autism is diagnosed. As I mentioned earlier, DSM-5, Diagnostic Statistical Manual 5, is the primary diagnostic criteria used. There are no reliable biomarkers for autism. The condition is diagnosed based on the child's developmental history and behavior. DSM-5 is a guide created by the American Psychiatric Association and is administered by a psychiatrist or neurologist, those who are trained by them. It looks at excesses and deficits in 3 domains: social, emotional, verbal, and nonverbal, behavior, and interest. Note that DSM-5 requires age 6 or 6 plus to have the diagnosis, but children can be tested earlier for red flags or signs for being at risk for autism spectrum disorder. There are other screening tools. These are the most commonly used tools that can be used earlier. MCHAT, which is modified checklist for autism in toddlers, administered to children between 16 to 30 months. Then the other one is CARS, Childhood Autism Rating Scale, used for children 2 years and older. There are more screening tools, but the about 2 are more common ones. Let's look at the signs of autism. And these are some of the signs that Robert had shown. Rarely responded to sounds, voices, or name, limited eye contact, did not show items for sharing, or did not share interests, lack of imitation, rarely pointed out to objects or to indicate his wants and needs, and he had limited range of facial expressions or gestures. Let's look at the signs in 18 and 24 months old. Typically, parents may start noticing these subtle signs, but may or may not be concerned yet. But if these signs are identified early, it can help in early diagnosis and intervention. Again, in 18 months, you see delay in communication, social skills, And then as they get to 24 months, they develop atypical speech or echolalia, which is meaningless repetition of someone else's spoken words. Little interest in games that are common for toddlers. They may demonstrate unusual, repetitive, or stereotypical behavior and unusual reaction to the way things smell, taste, look, feel, or sound, which points at sensory issues. I have put the next slide just for comparison. These are the two kids. One is neurotypically developing child and the other one is neurodivergent with the diagnosis of autism spectrum disorder. Let's get back to the case of Robert. So as I mentioned, all the signs that mother noticed at the age of 12 to 14 months of age. And since family had one child with handicap, mother kept a close eye on Robert's development. So at about 16 months of age, when she took him to the pediatrician, she brought these concerns to the pediatrician. She was not overly concerned, did not use any screening tool, and wait and see approach was advised as he was walking and physically looked normal. Her concerns grew more as Robert got older. He was irritable throughout the day. Parents dreaded simple routines with him. He was just getting difficult to manage. On friends' recommendation, she called the developmental pediatrician. Robert was 17 months of age. She used a screening tool, a modified checklist for autism in toddlers, MCHAT, and he was diagnosed with at risk for autism spectrum disorder and referred to early intervention program. Robert was evaluated at 18 months of age using Battelle Developmental Inventory Test, which is a standardized test, and showed delays in all areas. He was evaluated in the domain of cognition, social emotional, gross and fine motor, and self-care skills. I happened to be on the evaluation team along with the social worker and a speech language pathologist. As a team, along with the family, we made some realistic, short-term, concrete goals for Robert, and services were assigned. Again, I happened to pick up this case and started services after 2 weeks of evaluation to be seen 2 times a week. I had evaluated Robert, so I knew he had some sensory issues. We will look at Dr. Jean Ayer's sensory integration model, but first let me enlighten you on what early intervention program is and why it is beneficial to the families. It provides services to children between birth to 3 years of age with developmental delays or disability. It is in every state and the territory of United States of America. Services are provided for free if they're eligible, and there's no referral needed. Child can be evaluated for eligibility for free. And this program is not only for children, but for their families. So whatever services they need until the child turns 3. And why early intervention is crucial. So let's look at that, because it takes advantage of neuroplasticity, which is brain's ability to change in response to stimulation. During the period of plasticity, brain is resilient. Most axonal outgrowth begins at birth and ends at 2 to 3 years of age. So we have structural plasticity, experience and memories change brain's physical structure, and then we have functional plasticity when functions move from damaged area to undamaged area. The first year of life is a period of tremendous neural plasticity as the brain doubles in size from birth to 1 year, and the volume growth ends at 2 years. Brain is an essential organ, we all know that interprets all the sensory information you encounter, which is called sensory integration or processing. So let's look at the next slide on sensory integration or sensory processing. It is receiving information from the environment through our senses, Organizing it means interpreting and integrating it and using it to be able to function, which is sensory motor adaptation essential for functional skills. Hence, it is foundational to function. So sensory going in and from here, motor coming out. Child has to perceive sensations or sensory input to be able to respond, which is always a prerequisite for interacting with the environment. It is an innate neurobiological process happening in the brain, which is consists of countless neurons, neural pathways, and parts of the brain. And that's why it is called a sensory processing machine. We take information from the outside world from the commonly organized sensory system that includes various senses. So let's look at them in the next slide. We use these 8 senses to make sense of the world. We are all familiar with the first 5 senses: visual, auditory, olfactory, gustatory, and tactile. Movement is your vestibular system, and the structures are located in the inner ear and responsible for balance and coordination. You move your head to 30 degrees and the system is activated. Proprioceptive system gives us body awareness, helps us to know where our body is in space through neuroreceptors located in your muscles and joints. Then we have a lesser known sense called internal sensation or interoception, which is perception of internal sensations from inside the body. It facilitates self-regulation, hunger, pain, thirst, and internal temperature. It also tells us the threshold if it is high or low. For example, pressure of going to the bathroom. I think that's why it's such an important sense. Sensory integration focuses mainly on 3 systems: tactile, vestibular, and proprioceptive, as these are the most frequently occurring sensory integrative factors. The interrelationship between these 3 senses is complex. They are not only interconnected, but are also connected with other systems in the brain and are critical to our basic survival. So we talked about sensory integration, which normally in healthy developing children happens automatically, unconsciously, and without any effort. Now, what happens when there's a disruption in a system? Then we have sensory processing dysfunction, or SPD. Let's look at that. Sensory processing disorder has been organized under 3 umbrella terms, and then it is further divided into subcategories. Let's look at the first term. Sensory modulation disorder is the inability to quickly evaluate an incoming sensation for relevance and respond quickly and appropriately. It is again divided into 3 subsystems. Depending on the child's threshold for incoming sensation. And it may be different for each person. So each person has a unique threshold for responding. And it may not be same for all sensory modalities. Children who are hypersensitive or over-responsive have low threshold for incoming sensation. Infants and toddlers with autism may frequently perceive daily sensory events as threatening and may not like being held or cuddled, which may result in bonding issues with parents. Children who are hyposensitive or under-sensitive, under-responsive have high threshold and they do not notice their hands or face being messy. Moving on to the next subcategory under sensory modulation is a sensory seeker or craver. They often seek out sensory experiences like crashing into a pillow, or they may mouth toys or objects excessively. They want more and more and too much, and it is never enough. And most of us engage in this behavior like chewing gum or biting our nails. Moving on to the next umbrella term, sensory-based motor disorder, which is the inability to motor plan one's action in response to stimulation, like figuring out how to climb a couch or get on a ride on toy is called dyspraxia. Inability to stay balanced on a ride on toy or on an uneven surface is called postural instability or insecurity. Sensory discrimination is the last umbrella term, and the disorder means difficulty interpreting meaning of sensory input. It also allows you to compare various details, disregarding irrelevant information. Sensory discrimination is more apparent in older, school-going age children than infants and toddlers. And it can happen in any one of these sensory domains. So since it's not apparent in infants and toddlers, we will move to the next slide to look at some of the signs of sensory processing disorder. It is now considered a symptom of autism, as majority of children on the spectrum have significant sensory issues. From time to time, we all experience this. Too much sensory stimulation, like being at a noisy place, or too little sensory stimulation, like being in dark, confuses the brain and can cause temporary discomfort. Illness, fatigue, and stress can also interfere with smooth functioning. So what signs did Robert show? Robert covered his ears to loud noises, and he even screamed and cried. He also had issues with food textures. He did not like to try new things, and he did not want to be touched. Now, people who are hypersensitive or under-responsive and have high threshold for input, they cannot be touched enough. You will see them touching everything and everything that they see, including themselves and whatever is around them. And children may show little or no reaction to stimulation like pain, extreme hot or cold, or overreaction depending on their hypersensitivity or hyposensitivity. Robert also did not like his hair being brushed because he was hypersensitive. He was also sensitive to light. He got upset over clothing tags and textures. Now, sensory seekers are risk takers. They like to crash into things, and all of them can have poor coordination. Sensory evaluation is critical to determine child sensory preferences and challenges and threshold for various sensory stimuli. So let's look at the evaluation tools. And sensory integration is one of the most important areas to address when you need to start, and this is where you need to start your focus. The tools used in the diagnosis of ASD contain items related to sensory processing, but do not provide specific information. So we use Sensory Profile 2 for infants and toddler by Dr. Dunn. It's the most common tool that I used, and I used it with chart of that checklist, which is a checklist given to the parents and interpreted by professionals. The other checklist is this one by Sensational Brain. And also there are many informal checklists available online and in some books on autism. So what sensory challenges or preferences did Robert show? So we talked about he did not like being touched. So he had all these 4 signs pointed at that he had difficulty in modulating the tactile sensation. The next one, he chose to eat only certain foods, resisted teeth brushing, pointed at that he had difficulty modulating tactile input into his mouth. And he covered his ears frequently because he was hypersensitive. He hummed and used self-stimulation as a coping mechanism to avoid annoying sensations. He also had trouble feeding self and getting up and down the stairs and the couch, which meant he had trouble with motor planning and postural stability. Now, what happens when children have challenges in processing sensory input, like in Robert's case? So let's look at Robert's scenario. So he had sensory symptoms like tactile and oral defensiveness, which led to motor symptoms, delayed self-care skills, gross and fine motor skills, which led to behavioral symptoms, frustration, irritability, tantrums, and meltdowns. And I think someone has to unmute their system. I can hear some disturbance. Please, I request people who have not unmuted to mute themselves. Thank you. So behavioral symptoms will result in social symptoms like unpleasant family times together and limited social interactions. So now we talked about sensory integration, how it is foundational to function. Each skill forms the foundation for the next skill, and any disruption in it can cause sensory processing disorder. We looked at its signs and the evaluation tools. So now let's look at the treatment. How do we address the sensory processing challenges? By providing activities through sensory diet, which is nourishment for the brain. Most of us use sensory strategies even without knowing it, like drinking coffee or tea when we are tired or need to stay focused. We listen to the music to unwind and relax. We go jogging to release tension. But some people need more intentional approach. And we use this intentional approach in the form of a sensory diet, which was first created by an OT, Patricia Wilbarger, in 2002. Let me elaborate a little bit on that. Sensory diet is a tailored plan of activities designed individual child sensory needs. The goal is to get kids in just right state. And what does that mean? Let me just get a sip of water. Sensory diet is a tailored plan of activities designed to meet, as I said, in just to create just right state of mind. So that means to get overstimulated child come down from an overload state to a state of feeling calm, and the child who feels or seems sluggish to help them feel more alert. A sensory diet is prescribed only by OTs and it is monitored by them. It can also be carried out on a daily basis by a person who is trained by an OT, and it can be easily incorporated into a child's daily routine. What do these inputs do? These inputs provide stimulation in the brain, which causes release of neurochemicals that can last up to 2 hours, depending on the type of input, intensity, and the frequency. And some children may need the input couple of times a day to keep the flow of these neurochemicals steady in the brain throughout the day. Also remember, it does not cure the problem. We just provide the tools to help the child with sensory challenges. Activities should have a positive effect and it should not have any negative effect. If you see that, stop the activities right away. So a sensory diet was created for Robert, and we had these goals for him. To address the first goal, parents dressed him in full sleeve shirt and full length pants to create a barrier between his skin and his world. Light touch was avoided at any cost, and he was warned if new tactile experiences were introduced. And tags were removed from his clothes. To address the second goal, his environment was adapted. We worked with him in a quiet room with less clutter and lights dimmed, and toys were organized in a bin. And we planned to accomplish the next two goals through activities that were designed for Robert. But before we could start working with him, we had to establish a rapport with him, take his lead in determining his interest in toys and activities. Otherwise, it is difficult to engage them and to get their cooperation. In the next few slides, we will see some activities that can be incorporated in a child's sensory diet. And as we look at them, I will point out the ones that we used with Robert. We start with the most important sensation, touch, that is used in activities. Children with tactile hypersensitivity will avoid touch, as we saw in Robert's case. So first 4 activities we used with Robert, and I will talk more about brushing protocol. And these are the 2 activities that can be used with children who are hypersensitive and need more stimulation. Moving on to the next one, we used Wilbarger's brushing program with Robert, followed by 10 quick joint compressions. Mother created a sensory bin with various textures and objects, and we have his favorite toy in the bin here. For children who are sensory seeking, seek out experiences, or touch things constantly, fidgeting with toys or objects, for these kids, provide them with deep proprioceptive input. Let's the activities continue. When introducing a child to textures, especially with tactile defensiveness, as in case of Robert, stay with dry textures or items that won't stick to hands. Then move to wet items like water, paint, and then to sticky like slime and cornstarch. Take it slow and don't force a child to stick with a texture that they don't like. You can always come back to the texture at different times and try again. We continue with the activities. With Robert, we tried this, and this you can make a dough at home and have them play with it. Mother involved Robert in some baking. He's mixing some cake batter. We did not get to messy play with Robert, as he did not build enough threshold to tolerate this messy play. Next, we will look at the proprioceptive activities. As I mentioned, we use brushing and joint compression with Robert. We use compression weighted vest that he wore under his clothing. We used weighted blanket over his normal blanket at night just to help him sleep through the night. And these are the other activities that can be used with children. Something to chew on always gives a nice deep proprioceptive input to the jaws. And we use ankle weights while working with Robert on walking. It also helped to bring his heels down to the floor as he was walking occasionally on his toes. So let's continue with more proprioceptive activities. Heavy muscle work and resistive muscle action can calm and refocus children with tactile defensiveness, as was the case of Robert. Other activities include jumping and pushing heavy things across. When in doubt, prop it out. When you don't know where to start with a child, proprioceptive activities are always safe as they're calming and organizing to the nervous system. You can never provide a child with enough proprioceptive input. So if you don't know where to start from, this is where you will start. We'll continue with the proprioceptive activities. Weight bearing on both hands provides a deep input to the arms and legs. Proprioception works closely with tactile and vestibular systems. So I like to use this scooter board activity, which combines both the sensations. And if you introduce the ball play and encourage them to cross the midline, it will also promote integration of both right and left cerebral hemisphere. So let's move on to more to next set of activities, which are vestibular activities. These are the activities to activate and strengthen the vestibular system. However, use caution with them. Watch for changes in skin color, signs of nausea, changes in heart rate or breathing. Stop immediately if this occurs. By the way, vestibular sense is the first to develop in utero, and by 5 months of gestation, it is fully developed. So these are the activities. We use marching game with Robert. Initially, I had him climb on my feet, his back facing mine, and I provided some gentle downward pressure on his shoulders until he got used to the rhythm and to the pattern of walking. And then slowly he was able to walk by himself and march. We also introduced some musical instruments to him. When he got a little bit older, I think 30 plus months, and he started playing drum, which is nice. It's like a bilateral, simultaneous use of both hands, good bilateral activity. And we continue with some more vestibular activities. He tolerated back and forth rocking on his stomach, which was calming for him. We had to cover the ball with his favorite blanket, as he was still sensitive to the the ball felt. He only used infant swing as it gave him more security and more contact surface area. We will continue with vestibular activities, dancing with the baby. You can combine it with singing as an added additional auditory stimuli, but make sure the child does not get overwhelmed. Wheelbarrow walking is another activity that combines vestibular and proprioceptive input. Remember that activities can be alerting or calming based on the child, the day, and the moment. And the most important thing to remember is if one activity does not work, then don't do it. Simply find another activity that provides you with a desired outcome. Additional activities continued. These are a lot of fun to do with toddlers. I try to incorporate them in my treatment. They like tree and animal poses like cobra and frog. Now I'll quickly zip through the next few slides because of time constraints. So let's look at the visual activities. Instead of fluorescent lighting, you can use incandescent lighting, which is warm. That's what we use with Robert. And also we kept the area organized for Robert. You can also do all of these wonderful things. I like to position children this way for play. It gives a nice vestibular input and also proprioceptive input through their forearms. And then the mirror gives them a nice visual stimulation. You can put a tactile mat, or if it's too much, then you can just replace it with a black solid color mat. Let's look at the auditory activities. Auditory stimulation is critical to normal development in children. This is the primary stimuli your brain receives in order to get into creativity and learning mode. Even a simple rustling sound is enough to activate their brain. So these are some of the activities. We use noise canceling headphones to dampen the sounds with Robert. But it cannot be used with children under 2 years of age, as their auditory system is still delicate and maturing. We move on to gustatory and olfactory activities. Oral sensory processing not only involves taste, but tactile and proprioception too. and is influenced by the sense of smell. So these are all the activities. We use this vibrating electric toothbrush with Robert, which he really took liking to, and it relaxed some of his sensitivity. He even started helping his mother in brushing by placing his hand over her hand. Family dinner times are wonderful opportunities for smelling and tasting some of your food. So children enjoy that. Uh, and also massaging babies with various essential oils. Remember, calming scents are lavender, vanilla, and jasmine. Alerting scents are peppermint and citrus. So now we have come to the end of sensory activities. Let me tell you about medication, diet, and supplements. No proven benefits to any of them. Children under age of 5 cannot be given any medication. Um, Melatonin can be used for sleep in consultation with a pediatrician. In older children, meds can be prescribed to reduce anxiety, hyperactivity, aggression, and depression. Now, after providing all the wonderful treatment, what are the techniques for success? For any therapy or home program, consistency and establishing a routine is the key, as children thrive on routine. It may not work once, but keep trying. And as an adult, we all thrive on consistency and routine. Make it fun, set up an environment that is inviting with activities that are developmentally appropriate. Provide options and let them choose the activity or a toy to play with, because then it increases their chances of participation. Do not force any activity. And always important question to ask yourself is if the child is progressing. If not, then you need to change your goals or treatment strategies. Videotaping the child in therapy can prove beneficial for parents and caregivers. And vice versa. Family can videotape the child when expressing challenging behavior like meltdowns for therapists to analyze the behavior. Collaborate and communicate with other team members. Child may be seeing number of specialists, so keep an open communication so everyone is working towards the same end goal. Parents, the most important team members, and I cannot stress this enough. Educate and support them. Provide them with resources. Sometimes explaining the goals of occupational therapy and sensory integration process can often help parents understand their value in treating a child and can motivate their participation. Like Robert's parents helped us in modifying their environment, creating a sensory corner for him where he could go to relax and regroup, and also in carrying out treatment plans at home. Do not give them high expectations. If they expect neurotypical behavior, then educate them about neurodiversity. Now, let me share Robert's success story. In the 18 months that he was in early intervention program, he received developmental intervention 3 times a week with OT 2 times a week. So developmental interventionist was focusing on building his cognitive skills, and also some applied behavior analysis approach was used. He had made slow but steady progress across all of his developmental areas. Parents' participation and cooperation was amazingly helpful. He was much calmer and organized, and not in fight, flight mode or sympathetic nervous system overdrive. His mother made a comment that he had come out of his cocoon. She was relieved to learn that there were reasons behind some of his strange behaviors, which were, some of them were sensory issues, and that can be worked on. An exit Battelle Developmental Inventory Test, BDI, and sensory profile 2 checklists were re-administered when he was about to turn 3 and graduate from our early intervention program. He scored much better compared to his initial scores. He was transitioned to a preschool program in an integrated classroom with some neurotypical children and some with special needs, not all with autism. Robert's mother was so impressed with his progress and early intervention program that she quit her job and now works as a nurse for early intervention program. Now, I will move on to my last slide, which is on conclusions and recommendations. As we all know, autism cannot be cured or prevented because it is not a biological thing in itself, since behavioral label is not a disease. But there is hope. When treated with aggressive and consistent therapy, impact of autism can be minimized in their day-to-day life. Early diagnosis uh, leads to early intervention, which is proven to be associated with the best outcomes due to neuroplastic nature of the brain. And we learned that about neuroplasticity, that new connections are formed. Let me take a sip of water. And children may not get diagnosed until age of 6 or later, but we don't have to wait that long. Early signs, warning signs should be taken seriously and addressed. And children should be screened for developmental delays, especially for autism from age 18 to 24 months at their well child visits. Now, 96% of children with autism spectrum disorder experience sensory processing difficulties. So sensory motor intervention is one of the most frequently used and sought after treatment. While sensory intervention helps a child to find balance in the brain, the child will continue to need a variety of sensory outlets to help stay regulated, just like any well-organized adult. For example, the child might need to continue participating in swimming, gymnastics, or some kind of sports. Just an adult may need to continue participating in yoga or other forms of workout on a weekly basis. And lastly, today's presentation was limited to sensory-based motor intervention, one of the many strategies utilized in treating autism spectrum disorder. Often 2 to 3 interventions are necessary depending on the child's affected developmental areas. Keep in mind that children with autism can fall anywhere on the spectrum. Hence, there's no one line of treatment or one size fits all model. The process of deciding on treatment for the child with ASD can be confusing, overwhelming, and different for every child. So my recommendation as a therapist to you is to be in great connection with yourself and slow down, take breath breaks, and when in need of guidance, you should not hesitate to reach out to an experienced OT or a mentor for support. The goal of treatment should be to maximize child's ability to function by reducing autism symptoms and supporting development and learning. We live in a scientific world and we understand the sensory system, its function, and its impact when it is compromised. Then we will have better tools to address it and share the information with the family and the medical world, stressing the importance of early intervention and occupational therapist's role. And with that, I end my presentation. Thank you for your attention. And now I'll take some questions.
All right. Thank you, Nafeesa. That's a wonderful presentation, very informative. We have a few questions in the chat box. So
Sure.
there's a question from Mano Sujila. So Mano Sujila, I saw a question as well as a couple of comments. Would you like to unmute yourself and ask yourself? Okay, so I'll just go ahead and read the questions then. So the first question she asked is Wilbarger protocol evidence-based? Is there any supportive journals available?
Yes, it is evidence-based, but it has to be followed with proprioceptive stimulation, like joint compression.
Got it. So she also asked, is there any supportive journals available? So basically, is there any particular journal that you would recommend her to go and look for?
You know what? If she can send me the email, I don't have it right here with me, but I can send her the information on the journal.
Sure thing. So, Nafeesa, if you want to like towards the end, like if you want to type your email in the chat box, so that anyone who wants to email you can.
Yes.
Email. Okay. So the next one, again from Manosujala, is like activities on therapy ball gives vestibular stimulation as it is given passively. Sensory integration involves active participation. Here, active participation is not happening. So I think so. Shall we say this activity as a part of sensory integration? So she's asking if it's passive, can we consider that as sensory integration?
This is, I would call it sensory-based motor approach. I use sensory integration theory, but this is not exactly the sensory integration that Ayers has defined. Okay, and as an infant, you can do this actually. With the infant, you have to support them. So this is the modification of that.
Yeah, and also I think there's a fidelity form now, just to to ensure that whether it's a sensory integration activities or not. The SI entity came up with a fidelity form. Just FYI, people. So the next question I have in the chat box is, what about children identified late in rural areas, not even diagnosed? Where to start? In the OT perspective in terms of assessment and management. Please guide.
Wherever they are developmentally, you assess them, and wherever they are, you start from that point.
Sorry,
if they show delays in communication, then you start there. They may continue to have sensory issues as an adult, and you may address them as an adult. But my specialty is in infant and toddlers.
Sorry, Sir Narendra, can I speak? Yeah.
Sure, go ahead.
Yes. Sorry, yeah, I just ma'am, in case if we have some free resources which are available in terms of the format or something, because rural, like I'm serving in rural India, so here it's very difficult because parents no acceptance and all that kind of things happens. So we identify very late, and even the certification never happened in terms of that some from the psychiatrist or some panel. So it's not appropriate. So from where to start? That's what, if some resources are available in terms of forms from where.
Definitely, there's a wonderful website. If you look for what's the website? Hold on. It's called Turn Our Autism Around.
Okay.
And Partners in Autism. Also, there is, Turn Autism Around has a lot of good articles for parents that you can share with, a lot of resources available online. Just type autism and you will be guided.
Thank you so much.
Yeah, but never give this websites to parents, because there's a lot of information there and it could be very confusing. So just filter it out and just provide them with information on needed basis.
Got it. Thank you. Yeah, will do.
You're welcome.
Okay.
Good question.
So the next one is like from Sugasi Bongade, I guess, and she said, please send me the Wilber protocol. Sugasi, we would suggest you, we will put Nafeesa's email in the chat box towards the end, and then whoever wants it, if you could personally email her directly, that would be really good. Thank you. And that's a question from Kinjal Hemani, how to get autistic child interest in coloring and pre-writing skills.
You have to first evaluate why they are not interested. Is it sensory because they don't want to hold the crayon, or they are not interested? Then you need to step back and start where their interest is. If their interest is just exploration, then that's where I will start. And then you build that. It's not that you're not working, but you're working on building towards that skill so that you get them to the point where they can start coloring. So always take their lead and see. When you assess, you know what level they are. Maybe they are not at that level yet. And Karthik, you work with children. You can also add, give your input in that.
Sure. So there is another question there that what other sensory materials we can use for tactile issues, and specifically in India where we do not have access to standardized tools. I think like the question, I think that's a two-part question. One is talk about standardized tools. The other one is more about the sensory tactile materials.
Materials, you can use any materials from home. As OTs, we are so creative. You can use rice and beans, you can use different textures. I usually, our early intervention model is family-based, family-focused. So we don't use much material from the clinic. We ask parents to make at home, like sensory blanket. Just take various textures, sew them together. You can use like cotton balls. You can use shaving cream. You can make your, the chapati dough for them to play with. So those are the tools that you will, whatever is available at home. And, most of the household have these common items available. I hope that answers the question.
Yeah. And standardized tools is always a challenge in India, and we have to really like develop more tools pertaining to the Indian context. So that's something we need to work as a profession to develop something. So what I would suggest is basically we need to encourage our the master students or the researchers in India to really like focus on that area where we need to through a Delphi study, we could come up with some sort of a questionnaire and standardized tools and materials for the Indian population.
Definitely. These tools are also available online. Like if you go Google, sensory evaluation tools, and you will come with sensory profile tools for children from birth to 15 years old. The sensory profile addresses, there's a checklist starting from birth to 15 years of age. So there's a lot of material available. Also, you can go to the library and look at American Journal of Occupational Therapy, which has a lot of information. You can also access it online. And scholarly articles on Google. It provides a lot of evidence-based and a lot of research material available to you for reading.
Got it. Wow, we are getting like now, I think people are in a questioning mode. Like we have several more questions in the chat box, and I just for the time's sake, folks, I'm going to like definitely ask all the questions, read out all the questions that's in the chat box now. But from this point, my time is 8:11. One of the questions comes after this, I'm not going to read because we need to wrap it up. And definitely we will put the Nafeesa's email there, and feel free to email Nafeesa, madam, and get your questions answered.
Definitely.
So real quick, any link or guide for careers for autistic adults, like livelihoods in rural communities? If any link or organization that kind of really supports autistic adults is the question.
Yeah, adults I don't have, but I'll look into it and will email it.
Okay. How to deal with parents who have high expectations, and also when they compare that child with other typically developing child?
Yeah, you know what? You will need to slowly educate, because sometimes these parents are still haven't come to terms to accept the diagnosis. So just go slow and, just be positive. And I always say to the parents, take one step at a time. And, small increments that happens in child, celebrate it. So I will just educate the parents and encourage them to take one step at a time. And if they're looking for neurotypical behavior, neurodiversity is hard to explain. If they're not ready, just wait until they're ready to hear it and accept it.
Got it. So how to teach self-harm behavior in hyperactive child in low cognitive level? This is a question from Benita.
Yeah, then you need to have a behavioral specialist intervene and assess and find out what is the root cause. Every behavior, there's a reason behind every behavior. So first you have to analyze what's causing that behavior, what's triggering that behavior. Maybe keep a log when that behavior happens. Self-injurious behavior is very common in adult autistic children. And maybe it's some of there could be underlying issues like needs unmet or inability to express themselves. A lot of children have like ear pain that they cannot communicate and may just bite themselves. We had this one child and found out later on that he had a severe inner ear infection. So you have to always look at the underlying causes behind the behavior, and there's always one.
Got it. So any cost-sensitive investigation measures available to quantify the changes pertinent to functional plasticity? And this is a question from Ram Kumar.
Can you please repeat that question again?
So any cost-effective, sensitive investigation measures available to quantify the changes pertinent to functional plasticity?
I think researchers are still looking at that, and they haven't come up with any of that. Otherwise, we will be far ahead in understanding autism.
Got it. So Manasujila,
Not at least that I know of.
Got it. Anyone who wants a Wilbur protocol article or something, you have to email the speaker.
Yeah.
So that is okay. So I have just seen the 2.8.11 items already. So I'm a PT work in early intervention. Would like to briefly share a thought. So Rashida, would you like to unmute and quickly take a minute to share what you want to share?
Yeah, hi everybody. My name is Rashida. I'm a physical therapist working in New Jersey, a very, very close friend of Nafeesa. We are always sharing information because we both are in early intervention. Just to let you know that very often I have found that a combined session with a PT and an OT always helps both disciplines. And as far as talking about proprioceptive and weight bearing and giving the touch. So OTs appreciate at times when I go with them and I'm working on the proprioceptive while they are working on the sensory part, standing at the table and giving them the input while they are, trying to get the child involved with the sensory stuff, coloring or whatever it is, or touch and all that. So I thought I would just share that with you all. And
that's wonderful, Rashida. Thank you for sharing. And in ideal world, that will be very ideal to do that. But a lot of times it's not possible. Like with Robert, developmental interventionist would come after my sensory intervention, and she would have a good session. But we could never coordinate that. So what we did was we told mom to do certain things before she came in, so that he was in a right state of mind for learning with the developmental interventionist. So that we can also do, because parents are the ones who spend most of the time with child. We just provide 1 or 2 hours of therapy. So really involve the parents in that, and then they can also start understanding and appreciating the treatment.
So the final question that I'm going to ask is basically there is a question from Yashashwini Kumari about restrictive repetitive behavior pattern. It becomes a major concern for most of the parents. So what can be done to reduce restrictive repetitive behavior, like arranging days and lines?
Yeah, that's like so common in children, repetitive behavior. I would say just find out why that's happening. Is it they're doing it for visual stimulation? They are, doing it because they're overloaded with sensory information, and try various things. You have to just do like trial and error with things and see what works with the child. But just look into, their sensory profile.
For the time's sake, we need to stop here. There are some more couple of questions about. So I know with Nafeesa's permission, Nafeesa, I'm going to type your email in the chat box, and I'm going to invite Dr. Jyotika Bijlani to render the vote of thanks. And we need to wrap this up in a few minutes because we have another meeting. that we need to head to. Thank you.
Definitely. Thank you. It was a pleasure.
Dr. Bijlani, over to you.
Yes, Nafeesa, it was really, really a wonderful lecture. It's full of information, and I was so happy to listen to the questions and your answers, perfect answers, because I'm also a pediatric occupational therapist. So I really loved your lecture, and particularly working with the infants and the toddlers, which is again my specialty. I'm also working in neonatology and all, and how important it is to screen out these babies, identify these babies, and early intervention really helps them. So anyway, without wasting more time, because we have already taken more time. So thanks a lot on behalf of International Branch of ICAIOTA and the Academic Council of Occupational Therapy of All India Association of India. So we all have been collaborating together to hold these lectures. So it was wonderful. Thanks a lot for accepting our invitation.
Thank you
And
very
also
much.
thank Dr. Yeah.
Thanks. My
Nafeesa,
pleasure. My pleasure.
Yeah. And really, I think the lecture should have been for a longer time, because this is such a topic which cannot
Yes.
completed in just 45 minutes. So I should thank Dr. Vijay Suple. He's always very active, very, very active, and without fail, he's been organizing with these lectures, any lecture, any and variety of lectures. There's really a diversity, what I should say, he's been organizing. And Dr. Karthik Mani, these two, both of them, or I tell you, they are working so well. I really appreciate both of you, Dr. Suple and Dr. Karthik, and Dr. I think she's from UK. Yeah, they all. Yeah,
Gazala.
Gazala. She's also really, they have been working as all the board members and all that. So thank you very much, because I just come at the end of the lecture and thank you, but they have been organizing it without any, it's our academic council is just a name of namesake, but they have been doing everything. So thanks a lot. Thanks all the participants who have been attending and listening to you so well, because it's a really interesting topic. So thanks to speakers, thanks to all the organizers, thanks to all the participants. So thank you very much. Yeah, bye.
I just want to add. I just want to add one thing there, and it was a wonderful presentation, Nafeesa, and we can see from the questions we're getting right in the chat box, and it just came to my mind that we can have your guest lecture again next year sometimes, and we will have a little more time for people to ask the questions. So that just came to my mind. So we're looking at maybe 2023, July, August, whenever you are back in USA. Yeah. So thank you again. Thanks a lot.
No problem.
So,
God willing, we'll inshallah do that.
Yeah, thanks.
So everyone, don't post your email in the chat box. It's not going to happen. Right? We are not going to take down your email and send it to you. That is, and Nafeesa's email there, mrsnafeesa@gmail.com. Go ahead and email so that she can respond to you. All right. So thank you so much. I'm going to end this meeting for everyone. Enjoy the rest of your day wherever you are. Until we see you in the next webinar. Bye-bye.
Thanks, Mr.
Karthik, it's Mrs. Nafeesa@gmail.com. Mrs. Nafees, not Nafeesa. Mrs. Nafees.
Okay, let me put it again then. Mrs. Nafees. @gmail.com.
Not a at the end. @gmail.com.
Yeah. Is it right now in the chat box? I just put it, but anyway, yeah, I removed the A. Mrs. Nafees@gmail.com. Thanks, everyone. Bye-bye.
Thank you,
Yes, that's correct.
Thank you.
Thank you, everyone.
Bye-bye.
Bye-bye.
Bye-bye. Have a nice day. Thanks.